Hi, thank you all so much for participating in the Sodexo and Abbott Southwest Region Symposium. And thank you so much to Jillian for organizing all of this and allowing me the opportunity to present our work from Swedish Medical Center. We'll be talking about our 2021 performance improvement project that we used and that's made our system better. So I'm really looking forward to getting into this information with you guys. I'm Marina Warner. I'm the clinical nutrition manager for Swedish, and I'm fairly new to the management role, but I've had a great team of dietitians who've helped me get well acquainted with the HCA system. So definitely looking forward to the presentation. Let's get into it. Really quick, our conflict of interest, we have a contract with Abbott. They supply the majority of our formula, and Sodexo is my employer. Our medical center is a 408-bed level 1 trauma center located in Inglewood, Colorado. We have a fairly new dedicated burn unit, as well as a reconstructive center. In fact, we have people from all around the nation that comes specifically to Swedish to receive that very specialized care. For example, they do a lot of limb reattachments and digit reattachments. So we're well known for that. We're a comprehensive stroke center, and we're the region's neurotrauma and orthopedic provider. We use the Meditech system to communicate our care. And like I mentioned, I help support a team of 16 clinical dietitians. Today, we're going to be reviewing introductory concepts of quality improvement and considerations related to dietetics. I also wanted to offer very brief, up-to-date nutrition strategies in the management of wounds. I know that the other presentations at this symposium will be going into more detail about that, so definitely look into those. Those have been tremendous presentations, but we'll offer very brief strategies and updated evidence for them. I'm also going to introduce our 2021 performance improvement project, and we'll discuss the dietitian's role in getting involved with quality improvement. So, to start off, why do we need quality improvement? People make mistakes. We don't always make the best decisions, especially when we're working under time constraints and we have an abundance of patients to see, a lot of things can go wrong for us. We skip steps, we don't remember everything. There's a lot of things that can happen or that can go wrong in our care. The National Center for Biotechnology has been tracking some of the more common adverse events that we tend to see in medical systems, which include things like wrong site surgeries, misdiagnosing patients, pressure injuries developing, suicides, mistaken identities. These are some of the ones that are more common. I'm sure you've seen some of these things. I certainly have. To give you more perspective, in the United States, over 250,000 patients who receive medical care are going to experience some sort of adverse event. And they also estimated that 100,000 patients are actually going to die from the care that they receive. So this is a huge eye-opener to what the issues are, right? Humans providing care to other humans, those errors that we make, how can we minimize them? How can we improve them, right? Things we want to keep in mind. So what are some things that can go wrong on our teams, on our clinical nutrition teams? Nothing, nothing at all. In my time as working in dietetics, some of the things that I've seen, I've been late responding to a physician's consult, although I don't enjoy sharing that with everyone. One of our dietitians ended up selecting the wrong site for a TPN infusion, which put the patient at risk. We've seen pressure ulcers progress in patient, allergic reactions galore. I'm sure that someone's seen an allergic reaction somewhere, and misdiagnosing of malnutrition, which is can be very costly for medical centers. It's just some things to keep in mind. I don't know if you guys have had other things, but these are the things that I've seen go wrong on our teams. So we're not immune to it. So in addition to things that are going wrong, there are other reasons that we want to get involved with quality improvement. What can we do to improve the systems? What can we do to solve problems or or make things more efficient, right? These are things we want to be considering. Because we all make mistakes, we want to learn from those mistakes. We want to encourage people to get involved, even if there's a risk of making mistakes, right? Otherwise, people aren't going to get involved with the work that needs to get done. So how can we facilitate that? What can we do to address these issues that we see in our medical systems? So what is quality improvement? CMS defines quality improvement as the framework used to systematically improve care. It seeks to standardize processes and structure to reduce variation, achieve predictable results, and improve outcomes for patients, healthcare systems, and organizations. These are things that we want to improve. These are the reasons that we get involved with quality improvement. What can we do to improve the outcomes for our patients, right? Improve our healthcare systems. We want to keep these things in mind. Some of the main drivers of healthcare quality in America include the Joint Commission, which is one of the main drivers. We've got the Centers for Medicare and Medicaid, and our independent organization, the Institutes of Medicine. All of these different institutions provide different structure on how to improve the quality of care that we give. So if you guys have time to go through their websites and just get that information, learn more about this stuff, it's super, super important and helpful. They have quality improvement tools, additional standards, standards of practice, so that we're not, if we want to learn more about that, definitely encourage you all to do that. So what are the main reasons that we get involved? The Institutes of Medicine put together these 6 aims to improve healthcare for Americans. So things that we want to keep in mind and the reasons that we get involved. Obviously, we want to provide safe care. We don't want to have poor outcomes with our patients to risk their safety and to harm them in any way, right? Anything we can do to make things safer is paramount to the care that we give. We want to make sure that our care is effective, right? We don't want to do things that are not evidence-based. We'll want to do best practice, right? Staying up to date on the things that are new in science and what the literature is saying. Like, we have to make sure that what we're doing is going to help the patient. And this is proven through the science, through the research that comes out. So staying up to date on that is really important, and making sure that we're getting the results that we want for our patients. We also want to make sure that all of our care is patient-centered, right? That it's considering the values and the goals of what the patient needs and what they want, what they value, what their families, what's important to their family, to them, where they are in their journey of medicine or medical intervention, right? What do they understand? How do we address those things to make it more patient-centered? We want it to be timely, right? Obviously, you guys see these long wait times for patients to get into an outpatient clinic for a surgical procedure or to be seen by your provider, right? There's sometimes months delayed. What can we do to improve that? What can we do to get to our patients sooner? Not just our patient care, but how can we improve the communication in a more timely manner for the multidisciplinary teams that we serve? These are things that, what can we do to make that more timely so that the care can be, facilitated? How can we be more efficient with our scarce resources? Look what happened with COVID. When this pandemic was coming about, we had a shortage of masks, and we had a lot of different people all around the nation coming together to make more of that supply that was gone, that we went through so quickly. So what can we do to utilize our supplies more efficiently? Not even just with that, but our medical supplies, but our time. How can we improve and be more efficient with our time, right? We get 24 hours in the day. That's not changing for anyone. Our energy, right? Like, how can we be more efficient as teams and as a system? And my favorite, how can we be more equitable with the care that we give? How can we give timely, efficient, effective, and safe patient-centered care to everyone that we have the opportunity to help, regardless of their gender or their background, where they come from, what color skin they have, or what their religion is, right? How can we make it equitable to give people these outcomes, these improved outcomes. How can we improve our care? These are the reasons that we get involved with quality improvement. So just some things that we want to consider when we're trying to improve the system. And if we find things that are missing these components of quality care, what can we do about that as a team? Some things we want to consider just based on specific to our organization and the populations that we serve. We want to make sure that what we're doing is consistent with the mission, vision, and strategic direction of the organization we serve, that it's important to our patients and our multidisciplinary teams, to our administrative staff. We'll want to see if there are any standards of care or practices that are already out there so that we're not reinventing the wheel, right? And being inefficient with our time, and make sure that it's consistent with the 6 aims from the Institutes of Medicine. Is it safe, timely, effective, equitable, and patient-centered? So definitely good things to keep in mind. I put this list of really brief list of quality improvement tools. There are so many quality improvement tools all over the internet that you can find. These were some that I pulled from the Clinical Nutrition Manager's Handbook that I thought were a little bit more related to dietetics. Definitely encourage you all to look into them a little bit more, but just to give you some brief information about these tools, the Plan, Do, Study, Act model is a tool that's been used by hundreds of facilities, medical systems, and basically you'll find what the problem is, you'll figure out what options you have for solutions, and you'll pick whichever solution you want and test it. So with the Plan, Do, Study, Act model, you'll plan a very brief pilot study, you'll implement that short study or that smaller study, see what the outcomes are, and if they're beneficial, you'll implement it across the whole system. So it gives a nice little structure for how to organize that. Lean is a different type of tool. I was introduced to Lean when I worked at Denver Health. This was something that they were pushing to make things more efficient. Essentially, you'll explore a little more whatever process is, and based on that process, how can we improve the flow of those actions that you need to make it more efficient, make it more timely. How can we improve that system, that process that we're doing to make it more efficient, is what Lean consists of. The Six Sigma provides kind of like a structure for things to look for when you're addressing a problem, some things to consider, and how you address that problem. Transforming Care at Bedside is a newer initiative that started not too long ago. I guess this is more of like a newer tool to get frontline care staff more involved with the care that they're giving and the quality improvement initiatives. If people who are on the front lines or who are at bedside are able to see what they're the ones who have direct exposure to whatever the problems are, right? So if we could get them more involved in finding solutions for those problems, what are ways to make those systems more efficient or effective, we want to get them involved. And so this is a great way to facilitate that change that we need on our teams to continue evolving as teams. And so getting everybody involved is a huge thing. Anyway, there's a lot of information on quality improvement tools. Definitely encourage you all to look through them, find a way to, whatever quality improvement initiatives that are taking way, find something that presents that information effectively and use that to organize your project or your plan. There's a lot more resources, again, on the Joint Commission's website, on CMS website, and the Nutrition Care Manual also was a tremendous tool. I ended up using the Six Sigma tool to present my project and to organize my project. The Six Sigma organizes their information into a DMAIC acronym to go over the different steps that you'll want to consider when you're organizing your project. So it starts with, defining what the opportunities are, what are the problems, how can we measure the outcomes of those problems or what the problem is. We'll want to learn more about the problem and analyze, what the process is, what options do we have to make it better, and find a way to implement something that might make it better or improve the system. And if it works, how can we control it? How can we stabilize that new process or that improvement in the process? So I thought that this was an excellent tool for me to use just because it organizes it in a step-by-step process. It was neat because it helped me consider areas of the project that I I wouldn't have considered, so providing that like roadmap to conducting this project or organizing this project, I thought it was the perfect tool for us. I'm going to be using this tool a little bit later when I present the project, using that DMAIC acronym to just show you the steps that I took when I was implementing the project. But before we get into that, I wanted to really quickly talk about wounds, just because my project's related to wounds. So why are wounds a big deal? In the United States, the last Medicare study that was done in 2018 estimated that 8.2 million patients on Medicare developed chronic wounds. And this costs up to $97 billion for Medicare. They found that surgical and diabetic wounds were the most expensive to treat. And this is these are wounds that we see very often in our hospitals. In 2016, there were 130,000 amputations in the United States of patients with diabetes, and they found that 85% of those amputations came from the diabetic foot ulcer. So these are things we want to think about when we're helping patients, who need to get their diabetes under control and to manage their wounds. Huge problem. Also in the United States, many people are at risk of chronic wounds or having a wound that has decreased healing, right? Anyone who's immunocompromised, patients who have chronic illness, are patients with obesity or who smoke, patients who live with a lot of stress or have that impaired mobility in their home, an inability to care for themselves, and anyone who's malnourished. This consists of a lot of our population in the U.S. Also, untreated wounds increase in depth with time, right? If they're not addressed, they become infected. They can cause ischemia, which ultimately leads to our amputations. And as you can imagine, this impairs our patients' quality of life. So anything we can do to address these problems is paramount. Also, the development of stage 3 pressure ulcers in the hospital is considered a never event. These are things that should never have occurred, right? They're very serious, very preventable, and costly medical errors. And Medicare doesn't reimburse any of the treatment that we do to address these iatrogenic events that occur, right? So we have to find a way to prevent these. This is very serious. Since this is a CEU, I wanted to give you guys just some very basic, brief information on how to manage wounds. Again, we have one of our other presenters who went over this stuff in more detail, but just to give you some information, I ended up using some articles that were interpreting the 2019 clinical practice guidelines that were put together by the European Pressure Ulcer Alliance panel, the National Pressure Injury Alliance panel, I believe, and the Pan-Pacific Pressure Injury Alliance. But this came out in 2019. And I also ended up pulling some more information just to make it more complete from the core curriculum, as well as some articles from UpToDate, of which I included. So for anyone who's a newer dietitian, or those who don't have a lot of experience with wounds, just wanted to go over some of the wounds that I found to be considered mostly nutritionally significant wounds. And again, every wound is different, tells a different story of the patient, but some of the ones we want to keep an eye out for include our chronic wounds. And something that I found all over the internet, I found different information on what would be considered a chronic wound. For the purposes of being consistent with our guidelines, I pulled wounds greater than 3 months are considered chronic wounds from the core curriculum. But I did find other articles that talked about other things to consider when we're thinking of chronic wounds. Excuse me. One of the UpToDate articles that I saw said that if a wound hasn't improved in a week, hasn't minimized by 15% within the first week, that would be considered chronic. Also, I found that if it's not minimized by 50% within the first month, that's another indication that it's chronic. And then a different source, I think from the NIH, said that if there's no progression of the wound after a month or any improvement in the wound, it's also considered a chronic wound. These are all things that I think we should be considering as clinicians, but obviously anything more than 3 months is an automatic chronic wound. So these are things that we want to think about. Pressure ulcers are included in our chronic wounds, stages 1 through 4, any unstageable or deep tissue injuries and those that occur from medical devices. We've got our venous and arterial ulcers that come from, that lack of circulation that you see in patients with venous stasis or that lack of mobility, edematous patients. We've got our diabetic ulcers that worsen with time if their blood sugars are not controlled, and any wounds that we would consider non-healing wounds. And this includes, verbiage that includes things like eschar, wounds that are dehisced, that are non-healing, wounds that have gangrene or necrotic tissue. I have a picture here of the necrotic tissue, and I forgot to show the National Pressure Injury Advisory Panel talks about the different stages. I included pictures here just so that you guys have them. I know that you'll go into detail in the other presentations too, though, so that's good. But just to give you an idea of what the differences are in what the differences there that all the different wounds have as they progress, and things that we want to keep in mind. We also have our acute wounds, right? Things that require an increase in protein and calories, which include our burn patients, our patients who are admitted with trauma, any surgical procedures that, things like open abdomen that have a long healing time, and our treatments, wound vacs that suck out a lot of fluid and protein from our bodies. For patients who have those, we'll want to keep track of how much is being excreted and increase those protein requirements. Also skin grafts, amputations, things like the ostomy wounds that are healing. These are things that we want to be looking out for when we're screening our patients and when we're providing those interventions. So the guidelines talk a little bit about the importance of nutrition screening, and I'm going to go through the screening, the assessment, and the interventions very briefly, just so you guys can see the different steps that we needed to consider when we were going through our project. For screening, we always want to make sure that we're including a validated nutrition screening tool to categorize the nutrition status of patients with risk of pressure injury or those who have a pressure injury. So making sure that you have that tool to address any patients with wounds and to find them and screen them out. At Swedish Medical Center, we use the MST screening tool, which categorizes patients at risk based on their PO intake and their history of weight loss. We also want to make sure that we're conducting a comprehensive nutrition assessment for adults who are at risk of a pressure injury, who are screened to be at risk of malnutrition. And we also want to be providing a comprehensive nutrition assessment for all adults who already have a pressure injury, is what the guidelines say. So when we are going into the assessment aspect of our care, trying to understand that story behind the wound, because they're all different. Every patient's story is different. Every patient with diabetes has has different needs. Trying to understand that so that we can individualize that care is really important. So first we'll want to understand, what is the social and medical history of this patient? Are they coming in with diabetes? Are they coming in with, quadriplegia, things that are going to affect their risk of getting wounds or having wounds? What's their social history? Are they properly, do they have access to care, access to meals at home? Can they prepare their own meals, right? Anthropometric measurements, we want to make sure, are they at a healthy weight, or are they underweight or are they obese, right? Being underweight and obese puts patients at risk for having a pressure injury. We'll want to see, what is their biochemical, clinical data? Are they being admitted with showing signs of refeeding syndrome, right? This is indicative that their intake has not been the best over the last however long it's gone on for, right? So keeping an eye on those labs. What is their blood glucose doing? What is their A1C doing, right? How well have they been managing this diabetes that they're being admitted with? We'll also just want to understand a little bit more about what's been going on with their PO intake, right? What's their appetite like? Has it changed since they developed this wound? Are they taking any supplements that we should be aware of, right? That they might even be putting in place of their balanced meal. Do they know what a balanced meal is, right? Again, what is their food supply doing? Are they able to go out and have physical activity or prepare their own meals at home, right? Or address and implement the care that's recommended by their physicians, right? These are things that we want to keep in mind. Also, what medical tests and procedures are they going to have? Is somebody coming in who just got out of an XLAP, or somebody who needs a wound vac, right? Somebody who has a wound vac, are they being followed by wound care? What diagnoses do they have that can make their wound worse? When it comes to the nutrition-focused physical findings, the biggest thing we want to look for with patients who are showing signs of muscle wasting or fat loss, how bad is it? Like, how long have they gone? How long has it been since they've noticed these changes in their muscle? And a lot of patients can tell you themselves, yeah, I don't fit into my pants anymore. I completely no more muscle. I've lost so much muscle since this over the last, 1 month or 6 months or whatever the case, but making sure we're getting that history, right? Because if they're already showing signs of muscle wasting and fat losses, it's very clear that there's either malnutrition, a poor PO intake, or some sort of catabolic illness that is increasing their calorie and protein needs that we need to address as dietitians. So these are definitely things we want to be looking for when we're assessing our patients with wounds. And just remember that patients with wounds who are showing muscle wasting and breakdown of those fat stores, they're already breaking those down for a reason, and that's not going to promote the wound healing that we need. So they're already at increased risk. And that's why that malnutrition and pressure ulcer, those things, that's why we need to consider both of those things when we're assessing these patients. Also, we want to know in our physical assessment, we want to make sure that we're assessing their oral health and their swallowing function, just to make sure that that's not keeping them from eating. And this is all stuff that's going to help us understand and make our care more specific to the patient. Making sure we're addressing their chronic conditions that are affecting these wounds and causing that chronicity or the chronic non-healing wound that we're seeing. So definitely important to learn more about. I wanted to talk a little bit more about malnutrition just because this is so important for us to address as dietitians. Somebody who's being admitted with any sign of malnutrition as well as a wound, time is of the essence for them. We've got to get to these patients because they're already experiencing that breakdown of tissue that we want to try to mitigate or minimize as much as we can. And again, those who have a loss of lean body mass, it's been shown to compromise the wound healing that we see. So making sure we're addressing that is important. I also want to talk a little bit about the difference between overweight individuals and very thin individuals, people who are underweight. Being underweight, not having a consistent enough nutrition regimen that helps you maintain that healthy weight is really important to try to address with patients. Just because being underweight already minimizes your access to nutrition that helps keep the body healthy, as you're all well aware, but just minimizes the healing of those wounds that we want to address. Being overweight has a different set of issues. These patients are also at high risk of developing pressure injuries. Patients with obesity are prone to more skin infections. A lot of times they don't have the mobility or the access to certain areas of their body to keep clean, to treat properly the way that they were shown by their physician or recommended by their physician. Right, like that leads to further skin infections, the hygiene aspects of that. I don't know if you guys have heard of things like paniculitis, that inflammation that you find in between the skin folds. It's just hard to keep those areas clean all the time. We also see that with the lack of circulation that we see in our obese patients and that lack of mobility, it leads to the lack of mobility and circulation causes wounds to take longer to heal, and you see more dehisced wounds in this population, and as well as venous ulcers. And so with our patients with obesity, one thing that it talked about is very important to think about is making sure that in our nutrition interventions that we're providing sufficient protein and calories for the healing of the wound prior to promoting that weight loss is what we're learning now. So just something to think about. As far as the nutrition interventions that came from the wound care guidelines, we want to make sure that patients are are receiving that healthful diet, right? That balanced meal that's going to make them, it's going to expose them to all the different food groups that they need, especially things with protein and our vegetables and minerals for those vitamins, our vegetables and fruit that's going to expose them to the vitamins and minerals that they need for that skin healing, and making sure that they're staying hydrated. The calorie and protein requirements for patients with wounds continues to be 30 to 35 calories per kilogram, and the protein is at least 1.2 to 1.5, depending on the patient's condition. We want to make sure that if patients are not getting enough to eat, can we provide foods that are higher in calories or protein, or oral supplements that are, and those using supplements that are enriched with arginine, zinc, and antioxidants like vitamin C for any patients with stage 2 pressure ulcers or greater, right, who have malnutrition or risk of malnutrition. These are all things we want to try to incorporate into that care. If the patient's not able to tolerate their meals by mouth, what are the options that we have for nutrition support, and are they consistent with the patient's goals of care? Other things we can think about, to make sure that we're increasing that PO intake as much as possible. We'll want to, liberalize their diet restrictions. If they're on a diabetic diet, or if they're, on a low sodium diet and they're not eating, why would we keep them on that diet? We want to liberalize that to promote that nourishment they need. We want to offer clinical or nutrition counseling to address any barriers that are affecting our patients specifically, whether that be a lack of resources outside of home, connecting them with our social work teams. Do they need a speech language pathologist for swallowing difficulties? How can we support them? Do they understand the concepts of nutrition that are going to help them heal, right? Can we provide that education to them? And do they need assistance with meals? Are there, cultural and religious food beliefs that are keeping them from finishing the protein sources like pork and beef on their trays that they're receiving that they don't eat, right? They're not going to get that protein if it's not consistent with their religious and cultural food preferences. And providing a pleasant eating environment. These are all ways that we can try to make it improve that intake for patients, as I'm sure you're all aware. Some things that the guidelines talk about that we can do to make sure that we're providing that patient-centered care that we have. Obviously, understanding the bigger picture for each patient. There's not one regimen that fits every single patient, right? It's a matter of your clinical judgment, how you can address the biggest issues for the patient, right? So after you've individualized the care for the patient specifically, offering goals offering all of those different options to the patient and letting them select what is most in line with the patient's choices and preferences, right? And including the multidisciplinary and care teams as well as the patient in that decision making. What is the specific intervention that the patient wants to try that they think is most in line with their goals? And once we've decided that, what is the best? When should we follow up with that? What does the patient have any other information they should understand in regards to that intervention? Or do they have any questions about that, right? And then communicate that specific intervention to the rest of the team so that everybody knows what's going on with the patient. So without further ado, definitely want to introduce our quality improvement project for this year. This was such an opportunity for me. I was first introduced to wounds working with the clinical dietitians and technicians at Denver Health. I was a diet technician, but I was first exposed to nutritionally significant wounds during those 2 years that I worked there. And I always thought it was interesting what the dietitians' interventions are, right? How we have a big role in the lives of these patients. I also think it's so fascinating how every wound tells a different story of the patient and how we can make it specific with our training to address those things. I went on, in my internship, I was able to present on wounds and continue learning during the time that I've been a dietitian for the last 3 years. I definitely am very passionate about wounds. I think they're so fascinating. This was the perfect opportunity for me to get out of my comfort zone, learn more about quality improvement and continuing to practice quality improvement and bringing this information to the team and to you all. This has been such an opportunity for me. So I titled our quality improvement project, Improving Nutrition Screening for Patients with Wounds. And the objective was to enhance clinical nutrition screening process to maximize interventions for patients with wounds. So in a nutshell, we were able to enhance our screening process to catch more patients with nutritionally significant wounds by the daily review of a wound care consult list. So that's kind of the gist of what our wound was and of what our project was. So as we go through it, you'll kind of have an idea of all the moving parts that took place to implement this. And to give you guys a very brief explanation of what the timeline was for all the different events that took place. Starting in, it was over the course of 5 to 6 months that we got this implemented. In February, I was trained on the screening process. Come March, I noticed that I missed a patient on my floors that I was covering. At the time, I was covering the orthopedic floor. And then I connected with my team members to understand how this happened. And they gave me more support. In April, I started conducting chart reviews as the manager there, and I noticed that more patients were being missed who had wounds. So I began tracking the patients who were being seen late for wounds or those who were missed. In May, I started exploring what options I had, just noticing that we have so many people, that we had those patients missed. I wanted to find options for minimizing those patients being missed. And I organized this plan, discussed it with my director and with the lead dietitians, and I was able to implement it in July. And since then, I continue doing chart audits and tracking and investigating any other patients that are missed. So this is just to give you an idea of how long it took me to implement this sort of project. I will say I have no doubts that all of you can do it much sooner than I would be able to implement this. I think that this project might have taken me a little bit longer. Just my being a newer manager for the team, not having worked with the team, I was still trying to build, relationships with the people that I was working with, and I was hesitant to implement that change so soon on into starting. So it did take me a little bit longer to get that information, to have people get involved with this. And I definitely think you all can do it in a much smaller time frame, but this is how long it took me. So just to give you an idea, our original nutrition screening process included different aspects on how to screen out those patients with wounds to make sure they were assessed. Our patient list that we review on a daily basis is printed every morning for our dietitians. And this list includes all of the admitting diagnoses. So part of our nutrition screening process for wounds included looking for, in that admitting diagnoses list, were there any patients who had the diagnoses of pressure ulcers or injuries, diabetic wounds, and anything that indicated a non-healing wound. So that was one way that we caught patients with wounds. Another one was we had our physicians and our nursing staff verbally and electronically consult us through Meditech to see these patients, or the wound care team. And when we went to our multidisciplinary rounds, we also saw that we were also made aware of any patients who had wounds. So these were the ways that we were able to see patients with wounds. And with this process, we actually ended up missing 4 patients with wounds over the course of the 4 months that I was tracking those wounds. So this was the opportunity for us to address this. As I mentioned before, the Six Sigma organizes their information with the DMAIC acronym. And so I'll be going through each step to kind of just introduce the different things we'd considered when we were going through the information. To start with our defining opportunities, as you're all aware, we were missing patients with wounds, which delayed our care, right? They were either seen late or completely missed. And we just want to make sure that we're getting to those patients. So this was a huge opportunity for us. We tracked the patients who were missed, as well as did investigations of each one, why they were missed. And this is kind of how we measured those outcomes that we were having as a team. When it came to analyzing our information, we wanted to investigate why were our patients being missed. And what we noticed is that our admitting diagnoses list doesn't always include all of the patients with wounds. If somebody's admitted for like a, heart failure and they have a history of diabetes, you're not going to see a diabetic foot ulcer as their admitting diagnoses. Somebody who, anyway, you don't always see the wounds in the admitting diagnoses list. So that was one thing. We also noticed that we weren't always being consulted for these wounds, which was also problematic. But then with this whole implementation and this whole project and discussion that we had as a team, we noticed that there were also just discrepancies in clinical judgment on our team, which, tends to happen when we have all different types of dietitians, with different specialties and different years of experience, especially those related to wounds. So there was just a little bit of difference in that clinical judgment. So that's something that we're still addressing as a team, which has been excellent for us. Doing this quality improvement project has allowed us to have those conversations and to support those dietitians who are not as comfortable with wounds. So it's been really good for us. During this, step of the DMAIC, I reached out to other HCA facilities just to see what they were doing as a team, how they were screening out patients with wounds. I got a lot of different information, but some of the ones that we had considered, one of the sites recommended that I just have our wound consults print automatically whenever in our dietitian's office, whenever there's a consult placed. And that would have been an excellent option for us. Another site suggested that we could use the wound list, the wound care consult list that's generated in Meditech. And when I opened that up, that could have been a good option as well. I was able to connect with one of the nursing directors for the orthopedic unit at the time, and she's excellent. She ended up introducing me to one of the Swedish wound care reports that was generated specifically for Swedish, and it was much more user-friendly than Meditech was. And it's also allowed us with the review of this list. We didn't have to have that additional paper printing every day. So just having that access to that list, we ended up using that. It was more user-friendly. Honestly, it was a little bit prettier than the Meditech list. So I thought it made a lot more sense to use that one, a lot more user-friendly too. So we ended up using the wound care consult list to review on a daily basis. Part of our improving step, we implemented the daily review of that report, and it's provided through Power BI systems. I'm not sure if everyone's familiar with that, but it's an excellent application that organizes things to give you statistics at different numbers if you're tracking something. So the wound care report is very user-friendly, very easy to look at. The other reasons that we did it, it's just, we were able to organize this list by unit. So each dietitian just has to look up their unit and look through their floors to see if there's any new patients with consults. And it updates twice daily, which is also really good. By incorporating this, we communicated it to the team, explaining what the reasoning was for the implementation. We sent an email with trying to describe what the new expectations were for dietitians to review this list regularly. And then we followed up with the team to make sure they didn't have any questions or concerns related to the new process. So those are the steps we took to implement that. So just to give you guys a summary, the new screening process, it includes all of the things we had before in addition to the review of the wound care consults list. And so far, since we've included this, we've not had any patients. We've had all of our patients. The wound care consult list has caught all of the patients with wounds that we've seen so far. That's not to say that we won't miss them in the future, but so far, all of the patients have been added on that list with wounds. We had two situations where two of our dietitians didn't understand or just they had that difference in clinical judgment for two patients who were on the wound care list. They didn't think that they had to see those patients for whatever reason. So, we discussed that information with these dietitians just to kind of give them more information. But so far, this wound care consult list has caught them all. And we're continuing to do our chart reviews to see if there's any other patients that go missing. We're trying to encourage people to communicate when we're missing wounds just to see if there's anything else that we're missing. And so far, this initiative has really shown to improve our outcomes overall. So we've been very, very excited about it and happy with it. In the chart audits that I'm conducting with the support of my clinical lead dietitian, we're able to, we review any patients with wounds, we'll review to make sure that the information is consistent with evidence-based practice and the updated guidelines. And these are all things that we are looking for to give that feedback to our clinicians. And again, one of our future goals is continuing to grow our knowledge and invest in educating our dietitians about the importance of wound care. So this symposium was just an excellent opportunity for them to do that. But anyway, yeah, it's kind of what we're working on for the future. Just some things I wanted to share that I learned through this process. And I think that there were a lot of things, but these are some of the things that hit home the most for me. Some of the feedback I got was anytime that I'm implementing a new process or that anybody implements it, trying to make sure that you have very clear instructions in all what if scenarios, trying to address those questions that you're likely to have with this new wound care or this new process and project that you're implementing, trying to be as detailed as you can. Just to make sure that everybody has that information in writing. I think it's always very helpful. And I noticed that since then, all the other projects I've done, having them in writing has been so helpful. I think it's also important to communicate any new process during a clinical nutrition meeting. And so what happened was when I implemented this process, I had initially communicated it at one of our daily huddles, which included half of our team. So I think it's always best when the majority of the people are there, when everybody can have an opportunity to come and understand the difference, to hear it firsthand in person and address, have their questions answered, understand why we need it. I think it always helps when it comes from the person implementing that new process. So definitely recommend always disseminating that information at a meeting where more people are going to be involved, just so that there's not that confusion and that missed communication. I think that, so throughout this process, I think that I sought out feedback, and I always appreciate feedback, always want people to give me feedback. I will say with this specific project, I think that from the beginning, I just making sure that I was continuing to seek out that feedback, being in a new system known as Meditech and HCA, and working with a new team, just wanting to know from everybody, what do you guys have, any other ideas, any other, thoughts on this before we fully implement this? And then after we implement it, what can we fix, right? Continuing to seek out that feedback was so, so helpful. And it's something that really helped me as well with this and with all the projects I've done since then. So, and then the other thing is, explaining your reasoning for facilitating that change, or so for bringing that change helps to facilitate that change. It's hard for people to deal with change unless they understand the need for it. And I that's definitely something that I noticed with this project specifically. So how can dietitians get involved with quality improvement? Speak up, obviously. Say what you think in a way that's professional, respectful, courteous, as you all do, I'm sure. We want to make sure that people have a voice on the team, that we're listening to what people say, that we at least consider what their ideas are, what their plans are, what their goals are, what the problems are, right? Making sure that we're contributing on our team. Our thoughts are our contribution on the team. So please speak up on the team. Anybody can get involved with quality improvement. We can all make our team better. We can all evolve the team. We can all make things, improve the systems on our team. We all have direct, direct exposure to what the problems are. So bring those things up. You don't have to be on the leadership team. You don't have to be the manager. You don't have to be on the quality improvement committee, right? You can be anyone. What can you do to make it better? How can we evolve as a team, right? One person getting involved is great. Fantastic, right? 2 people is double that, right? 3, 4, 5 people getting involved improves things on a much greater scale. So if everybody can get involved, it's just going to help the team continue to evolve. We always want to be on the lookout for process or systematic issues that we're seeing, right? Finding ways to learn more about quality improvement, which you guys are doing by watching this, right? Having that, growing your experience and your knowledge so that you can be more valuable to your employer and to your team, right? Continuing to invest in yourself so that you can solve more problems for others. Helping your colleagues and your peers with their quality improvement projects, to get more experience, to get more comfortable with this sort of thing. Finding ways to make sure we're staying up to date on our practice, whether that be hosting or attending journal clubs, attending or presenting at seminars and conferences. I'll tell you now that I have learned so much putting this information together for you guys, and I really hope you guys learned something too. But it's just it's so important to get involved, to bring information to your team, right? If you find, if you've structured in time for learning on a regular basis, even if it's once a week, once a month, once a day, whatever you like, right? Like, you're going to be learning new information. You can bring that back to your team so you can keep your team up to date, and so that you guys can be conducting evidence-based care, right, to improve outcomes for your teams. And then I recommend looking for a quality improvement tool after you've done some digging. Find a way to organize your thoughts and provide that reasoning for the need for your quality improvement project, and pitch that to your leadership team and to your colleagues, and just tell them what you're thinking. Make it better. How can we continue to evolve as individuals and as team? And how can we facilitate quality improvement on our team? There's this, Martin G. Moore he has a podcast, a leadership podcast, and one of his podcasts is titled "Create a Culture of Excellence Over Perfection." And this is so special to me because working on all the different teams that I've been on, at Denver Health, at Swedish Medical Center, in Puerto Rico, in LA, I've worked with so many different types of people, and being able to contribute on a team and to feel appreciated and valued, and that my thoughts are not going to be rejected, those things are all important, right? When somebody takes on a project, it's hard to share your work with people and bring your thoughts and your contribution to the team if the team is going to blatantly not accept your thoughts, right? And they're not always going to be accepted, but to be considered, to have a voice, right? As managers and as leaders and as a team, I think that it's so important that we're expecting the work to get done. There's not always one specific way that it should get done. There's so many different ways to do our jobs, and we all have different ways of doing them. And I think that we have to be open to everybody's individual way. And instead of, having that culture of perfection, what does perfection even mean? I think perfection for one person is different than perfection for someone else. And if I, as a leader, am expecting my team to provide only perfect results, only perfect outcomes, they're not going to get involved. They're not going to feel that they can meet my expectations, and they're likely not going to be able to, because who knows what perfection is, right? But if I can just expect them to do a good job, respond to what the problem is in the ways that they know how, based on their skills, based on their abilities, and support them and give them that feedback, constructive feedback that they need, it really empowers them. So having that is really important. The other thing is, we want our team members to feel safe and to be respected when they're bringing information to the team, right? We don't want to discourage them from speaking up in our group huddles, and sharing their ideas makes people vulnerable, right? Telling people what we think. We have to make sure that we're inclusive of everybody on the team, everyone. That includes the person that we don't get along with the best, the person who's not very nice all of the time, right? Somebody who, we want to accept everyone and support everyone on the team so that people feel like they're on a team. Also, having brainstorming sessions really helps to find problems, to find options for addressing those problems. When more people get involved on the team, when more people have a voice, we get more options for addressing those problems. And again, two minds are better than one. So getting more people to get involved is so important. And the last thing, I'll say is not being afraid to take risks. There's so many things that need to be addressed in all of our systems in the world. And how can we need to not be afraid to make mistakes. We're going to make mistakes. How can we learn from our mistakes? How can we make things better? We want to do these things, and not being afraid to take risks, encouraging people when they make mistakes, how can we make this better? Keeping a smile on our face and supporting each other is really important. And I'll leave you guys with one of my favorite quotes. It says, 2 heads are better than one, only if they contain different opinions. So think about that. We want people to get involved. We want people to make things better. More people getting involved it's going to help make more things, improve more things. And so I hope that this resonates with you all. It's so much fun putting together, and thank you all so much again for your time. If you guys do have questions, I'm going to be sending out an email with this link, and you guys are all welcome to email me with any questions that you have, any additional information that you need from me, so that we can get you guys what you need. Thank you so much again, and have a nice day.